Lesson 12 will further our discussion of pediatric cardiopulmonary conditions and the necessity to provide intervention in the acute, rehab, and home care settings. The first pediatric diagnosis we will investigate is Down syndrome, which is associated with cardiac defects such as atrioventricular defects, ventricular septal defects, atrial ventricular septal defects, and tetralogy of Fallot. In addition to cardiac defects, sleep apnea is common and deconditioning as well. Patients benefit from nutritional counseling, recreational opportunities, and physical activity. DiGeorge syndrome is an immunodeficiency disorder that is caused by deletion of chromosome 22. They may exhibit cardiac anomalies, abnormal facial features, thymic hypoplasia, cleft palate, and hypocalcemia. Cardiac surgery, medications, or thymus transplantation are typical medical treatments. Vater association is a non-random association of symptoms which include tracheoesophageal fistula, and Marfan syndrome is a connective tissue disease that is associated with aortic aneurysms and aortic mitral insufficiencies, as well as depressed sternums and cardiopulmonary involvement. Williams syndrome occurs due to deletion of the long arm of chromosome 7 and is associated with supravalvular aortic stenosis and supravalvular pulmonary stenosis caused by changes in elastin production, and fetal alcohol syndrome may have associated cardiac anomalies such as VSD, tetralogy of Fallot, pulmonary valve stenosis, and PDA. Other conditions that may cause general muscle weakness, including diaphragmatic weakness and medical fragility, include cerebral palsy, spina bifida, muscular dystrophies, and atrophies. Cerebral palsy patients are vulnerable to frequent upper respiratory infections, aspiration, and pneumonia. Children with spina bifida, particularly those with Arnold-Chiari type 2 malformation, may have associated ventilatory problems such as inspiratory stridor, central apnea, and respiratory distress. Duchenne muscular dystrophy and spinal muscular atrophy are both characterized by progressive muscle wasting, weakness of the respiratory muscles, and in the case of the latter, progressive respiratory failure. In this case, supportive care is indicated, but for the majority of children with conditions with cardiopulmonary manifestations, lifelong interventions and the ongoing need for cardiopulmonary rehabilitation are indicated. Special facilities that concentrate on children with their specific disorder are integral for preserving maximum quality of life. The examination of the pediatric patient with cardiac and pulmonary disorders begins with a thorough history. This history is obtained from the medical record and family, or if the child is old enough, the child themselves. Observation of the child is important, and it may include whether the child is on ECMO, a ventilator, intubated or trached, or on supplemental oxygen. Observation of nutritional modes such as gastrostomy tube or nasogastric tube and lines such as intravenous central femoral lines or ECGs or tubes such as chest tubes or Foley's should also be assessed. Examination of the chest should include general shape and mobility and use of accessory muscles. Normal vitals for infants and pediatric patients are described in Table 20-2, with premature and newborns 3 kilograms or less having an average heart rate of 100 to 180 per minute, a respiratory rate less than 40, and a systolic blood pressure 42 plus or minus 10, or 60 plus or minus 10. Children 4 to 5 and 16 to 18 kilograms having an average heart rate of 70 to 110, a respiratory rate between 20 and 30, and systolic blood pressure 99 plus or minus 25. Aerobic capacity of a child can begin with step tests or walk tests, which will be fully described in future lessons. Strength testing may be done observationally in young children or children with cognitive impairments and is performed by a physical therapist, but all medical personnel must be aware of any limitations when formulating a rehabilitative care plan. Subjective measures such as perceived exertion and dyspnea on exertion should be noted. The patient's family situation should also be a consideration, since additional stressors, such as missing job time, parents whose primary language is not English, etc., may impact the long-term success of any rehabilitative or home care program. Goals for all interventions are to increase strength, flexibility, functional mobility, breathing pattern, airway clearance, and vital signs. Rib cage mobility is usually performed by the PT, but strength training can be done by both PT and RT. An inspiratory muscle trainer may be used if the patient is old enough to follow directions. There is no definitive treatment protocol for children, but adults with COPD are often instructed to use 30 minutes per day, 5 times per week, for 5 weeks at 40 to 50% of maximal inspiratory pressure. Breathing patterns beginning around age 2 should note no activation of accessory muscles during quiet breathing, and games that encourage diaphragmatic breathing, such as placing a toy on the child's stomach to, quote, give it a ride, may establish more normal and efficient breathing patterns. Airway clearance techniques are especially important with children with cystic fibrosis or bronchopulmonary dysplasia and may include CPT, postural drainage, high-frequency chest wall oscillation, or HFCWO, positive expiratory pressure, and sinus spirometers, huffing, and assisted cough. Special considerations for treating children is that Trendelenburg should not be used in children younger than 2, and children with CF may reflux and aspirate without observable signs with postural drainage when in Trendelenburg, so many CF clinics discourage its use. HFCWO is generally used in children 2 and older in CF clinics, and absolute contraindications are unstable head and spinal or rib cage injury or active hemorrhage. Relative contraindications are sub-Q emphysema, recent spinal infusions or skin grafts, burns, open wounds, bronchospasm, TB, pacemakers, or chest wall pain. Bubble PEP is a fun and effective way to provide both positive expiratory pressure and oscillations similar to an acapella. And kazoos, party blowers, pinwheels, etc. can encourage children to take big breaths like an incentive spirometer. Huffing, assisted cough, and cough assist machines may also aid in the removal of secretions. The principles of cardiovascular and endurance training are the same for children as they are for adults. Both groups should be monitored for heart rate, oxygen saturation, rating of perceived exertion, and dyspnea on exertion throughout the activity, and activity should be increased over time as tolerated. Any activity should be stopped if the child exhibits chest pain, perceived exertion greater than 17, dyspnea 4, dizziness, visual changes, pale or ashen appearance, new onset joint pain, heart rate greater than 80% maximal heart rate, and O2 saturation below 90%.